Welcome back. It is so great to have you sitting down with us again.
It really is. We've got a lot to cover today.
We absolutely do. You, the listener, are the reason we dig into these massive stacks of research. And today, well, we have an incredible journey ahead.
A pretty wild one, honestly.
Yeah. But first, as a quick reminder for those watching the videos, this is the second and last deep dive of our appendicitis series. Please make sure to subscribe and enable notifications and let down the topic you want for our next deep dive in the comments below.
We really do rely on your comments to figure out where we're going next, so don't be shy about that.
Definitely don't.
Yeah.
So, what is our mission for today's deep dive? We are finishing our exploration of the appendix by looking at the absolute highest stakes scenarios.
Right, because in our previous discussion, we looked at your standard, everyday acute appendicitis.
Exactly. But today, we're moving way past that. We're diving into the incredibly complex world of appendicitis in pregnancy.
Which is incredibly stressful.
Oh, I can't even imagine. And we'll also cover the meticulous detective work of post-op checklists and the, frankly, shocking discovery of rare appendix tumors.
Yeah, we all tend to think of an appendicectomy as a completely routine procedure. It's the classic bread and butter surgery you hear about all the time.
Right.
But today, you'll see why a surgeon actually has to act as both a master detective and a bomb disposal technician when things take an unexpected turn.
A bomb disposal technician. I like that analogy.
It fits perfectly, as you'll see. We're going to look at some scenarios that will completely change how you view this little organ, including a rather terrifying phenomenon known in the medical world as jelly belly.
Jelly belly.
Huh.
I mean, it sounds like a candy, but as we'll soon find out, it is anything but sweet.
Not sweet at all.
Let's start with the highest stakes imaginable, though. Appendicitis during pregnancy.
The hardest scenario to navigate.
To set the landscape here, the data points out that appendicitis is actually the most common extrauterine surgical emergency during pregnancy.
It happens in about 0.5 to 1 per 1,000 pregnancies.
And it's slightly more common in this second trimester, right?
Yeah, statistically speaking.
Okay, let's unpack this. Because there's a major medical myth out there about how this actually feels for the patient.
Oh, the migration myth.
Yes. The old school teaching often says that as the uterus expands during pregnancy, it pushes the appendix way up into the right upper quadrant of the abdomen, changing where it hurts.
That's a myth that has lingered for a surprisingly long time.
It's still in some textbooks, isn't it?
It is, but modern clinical tracking shows us that
Diagnosing this in a pregnant patient just sounds like one of the most nerve-wracking dilemmas a surgeon can face. It's this massive balancing act.
it really is. Say a surgeon operates because they suspect appendicitis, but they get in there and the appendix is totally normal.
Right, that's what we call a negative appendicectomy.
And it's a huge deal. Even though the appendix was fine, just the physiological trauma and stress of undergoing that surgery and anesthesia,
It carries risks.
major risks. It carries a 4% risk of fetal loss and a 10% risk of preterm labor.
That is a terrifying gamble.
Yeah.
You don't want to operate if you don't absolutely have to, knowing you're introducing those kinds of risks.
Exactly.
You can completely understand why a doctor might hesitate and want to just wait and see.
You'd think so. But what's fascinating here is what's known as the golden rule in pregnancy regarding appendicitis.
And that rule is,
As scary as those surgical risks are, the danger to the fetus from a perforation, meaning the inflamed appendix actually bursts inside the abdomen, is vastly greater than the danger from the surgery itself.
how much greater?
If that appendix perforates, the rate of fetal loss skyrockets from a baseline of 3 to 5% all the way up to a devastating 20%.
20%. Okay, so the math changes completely.
It does. That's why the ultimate enemy in this scenario isn't the surgery, it's delay.
So no waiting around.
Non-operative treatment, like just giving antibiotics and waiting, is absolutely not recommended. Surgery is mandatory. You cannot wait and see.
So if delay is the enemy, but you also really don't want to perform a negative appendicectomy, what is the exact action plan? How do doctors safely figure this out?
Obviously, imaging is your best friend here.
Ultrasound is generally the go-to because it doesn't use radiation, making it completely safe for the fetus. But there's a catch, right?
There is a catch. As the pregnancy progresses into the later trimesters, ultrasound really loses its sensitivity.
Because of the size of the uterus.
Think about it. There's a growing baby, an enlarged uterus, and a lot of shifted anatomy in the way. It becomes incredibly difficult for the sound waves to get a clear picture of a tiny inflamed appendix hidden behind all of that.
And that is where MRI steps in. I was surprised to learn that MRI is highly sensitive and totally safe during pregnancy.
It's become the preferred choice when the ultrasound isn't giving a clear answer.
And once the diagnosis is confirmed, the surgical approach is actually quite reassuring. Laparoscopy, which is that minimally invasive keyhole surgery, is considered safe in any trimester.
Yes, but they don't just go in blindly.
Right. The surgeons specifically utilize something called the Hasson technique. Can you break down what that actually means for us?
Sure. Normally in a laparoscopy, a surgeon might use a sharp-pointed instrument called a trocar. They puncture the abdominal wall so they can insert their camera.
So pushing it in.
Right. But pushing a sharp instrument blindly into an abdomen that's largely taken up by a pregnant uterus is incredibly risky. So the Hasson technique is essentially an open entry. The surgeon makes a small, careful incision and manually dissects down through the tissue layers under direct vision.
So they can see exactly what they're doing.
Until they safely reach the inside of the abdomen, only then do they secure the port. It guarantees they don't cause unintended harm to the uterus.
It's a brilliant adaptation. It really highlights how specialized medical protocols adapt to protect both patients.
Absolutely.
But let's transition our detective metaphor to a new scenario. Let's say the surgery is done, the appendix is out, the patient is recovering in their hospital bed.
But a few days later, they're just unwell.
Spiking a fever, feeling terrible, what happens now?
This is where the surgeon truly has to put on their detective hat. They use a very systematic, top-to-bottom clinical checklist to hunt down the problem.
A physical checklist.
Yes, and it requires intense critical thinking because you have to connect a patient's generalized, vague symptoms to very specific, hidden surgical complications.
Let's walk through that checklist with you. It starts right at the surface, naturally. The wound itself.
Correct. The very first thing you look for is a wound infection or an abscess right at the incision site.
How common is that?
This happens in about 5 to 10% of cases, usually showing up around day 4 or 5 after the surgery. It's typically caused by a mix of gram-negative bacteria and anaerobes.
Let me stop you there. Anaerobes. Specifically, there's a bug called bacteroids that gets mentioned a lot. Why are these specific bacteria such a problem in a surgical wound?
Well, anaerobes are bacteria that thrive in environments without oxygen.
Okay.
When a surgeon closes up an incision, they're creating a sealed, oxygen-deprived space.
I see.
If bacteria from the infected appendix manage to contaminate those tissue layers on the way out, that closed wound becomes the perfect breeding ground for anaerobes like bacteroids to multiply and form an abscess.
That's a perfect storm.
Mm.
So if the wound looks clean, the detective work moves deeper. The abdomen and the rectum.
Yes, the surgeon needs to check for a pelvic abscess. Because gravity pulls fluids down into the lowest part of the pelvis, infections often pool there.
How do they find that?
Finding it often requires a rectal exam to feel for any abnormal bulging or localized heat. Intra-abdominal abscesses occur about 8% of the time.
And these present a bit later, right?
Now, these tend to present a little later, usually 5 to 7 days post-op. The patient will suddenly develop a spiking fever, profound malaise, and anorexia.
Meaning a complete sudden loss of appetite.
Exactly.
And to diagnose that deeper infection, you use a CT scan or ultrasound. But the treatment usually isn't opening the patient all the way back up.
No,
They
thankfully.
use percutaneous drainage, basically using imaging to guide a needle and a tube right through the skin to drain the infection out.
It's far less traumatic than a second open surgery.
So we've checked the wound, we've checked the deep abdomen. The checklist doesn't stop there. The protocols say you absolutely have to check the lungs and the legs.
You do.
Wait, why on earth are we looking at the lungs and legs for an abdominal surgery complication?
If we connect this to the bigger picture, the body is an interconnected machine. Think about a patient who just had abdominal surgery. Their stomach muscles hurt incredibly badly.
So they don't want to move.
Because of that pain, they aren't taking deep breaths. They're taking shallow, tiny breaths.
So wow.
When you don't breathe deeply, the tiny air sacs at the bottom of your lungs can collapse, a condition called atelectasis.
And that leads to pneumonia.
Those collapsed, poorly ventilated areas are prime real estate for a lung infection, leading directly to pneumonia.
Wow, so the abdominal pain literally causes the lung complication. And the legs.
It's the same principle of immobility. The patient is lying in bed, not walking around. Without the leg muscles pumping, blood pools in the deep veins of the calves.
And that's where you get a clot.
That sluggish blood can form a clot, a deep vein thrombosis, or DVT. It's a deadly risk because that clot can break off and travel to the lungs.
It's amazing how a checklist forces a doctor to look past the obvious surgical site. Now, the checklist also calls out the bowel itself, specifically something called paralytic ileus.
Paralytic ileus is essentially when the bowel just goes to sleep. The normal rhythmic contractions that push food through completely stop.
Which is somewhat normal right after surgery, isn't it?
A little bit of this is normal right after the trauma of surgery, but if the bowel halts for more than 5 days, and that's accompanied by a fever, intra-abdominal sepsis must be heavily suspected.
So the infection is paralyzing it.
The body is so overwhelmed by infection that it's literally paralyzing the gut.
Another bowel complication to look out for is a fecal fistula. This happens if the stump of the appendix, the little bit left behind on the intestine where it was tied off, actually leaks.
Yes.
This is more common if the tissue is severely inflamed and degraded, or if the patient has an underlying condition like Crohn's disease that compromises the bowel wall. And just to round out the bowel complications, looking long-term like months or years after the patient goes home. Adhesive intestinal obstruction is the most common late complication.
Oh, absolutely.
Scar tissue from the surgery can create internal bands that eventually pinch or block the intestines, almost like a rubber band wrapping around a garden hose.
It's a stark reminder that the timeline of complications can stretch out for years.
Speaking of surprising things on this checklist, there's one item that completely threw me. It is the strangest thing to check after an appendix surgery. The patient's eyes.
Right.
You're looking for jaundice, a yellowing of the whites of the eyes.
Mm.
How does an infected appendix in the lower right abdomen cause yellow eyes?
It sounds totally disconnected, doesn't it? But this raises an important question about how our circulatory system is wired. There's an incredibly rare but absolutely deadly complication called pylophlebitis.
Also known as portal pyemia.
Yes. What happens is that infected emboli little clumps of bacteria and clotted blood from the site of the infected appendix break loose and travel through the bloodstream.
But why the liver? Don't blood clots usually go to the heart or lungs?
Usually, yes. But the venous drainage of the appendix is unique. The blood from that part of the intestine doesn't go straight to the heart. It drains into the portal vein system.
Okay.
Think of the portal vein like a dedicated high-speed superhighway that carries all the nutrient-rich blood from your digestive tract straight to the liver for processing.
Oh, wow. So those clumps of infection get on the superhighway and get delivered right to the liver's doorstep.
Exactly. And once those infected emboli hit the liver, they seed the tissue and cause multiple liver abscesses.
That sounds horrific.
The liver becomes so inflamed and damaged that it can't process bilirubin properly. And that bilirubin buildup is what causes the jaundice, the yellowing of the eyes.
Are there other signs?
The other telltale signs are a very high fever and rigors, which are severe, uncontrollable shivering fits. So checking the eyes is a quick, vital test to make sure the infection hasn't taken that deadly detour.
That is the definition of a high-stakes catch. It really goes to show why doctors can't just skip steps on that checklist, even if a symptom seems completely unrelated.
You can never skip steps.
Now, moving on to the next section of our deep dive. A question that you, the listener, might be wondering, can appendicitis happen more than once?
It's a great question.
We usually think of it as a one-and-done emergency. You
Yeah.
get it, it comes out, end of story. But the answer is actually yes.
It's a surprising yes. There is a recognized condition called recurrent acute appendicitis. It's defined as chronic or recurring episodes of lower abdominal pain.
But wait, how does that work? I thought if the appendix got blocked, it just swelled up until it burst.
Usually it does, but in recurrent cases, it's caused by an incomplete, self-limiting obstruction.
Like a partial block.
Think of it like a sink that's only partially clogged. Something blocks the tube of the appendix, maybe a small piece of hardened stool or swollen lymph tissue.
Right.
The appendix gets inflamed, it hurts, the patient feels terrible. But before it reaches the point of bursting, the blockage manages to cleave itself.
It just unblocks.
The sink drains, the swelling goes down, and the patient feels better.
It's like the boy who cried wolf, but inside your abdomen. And there's a clinical note that really stood out to me. If a doctor takes a very careful history from a patient presenting with what looks like their first major attack of acute appendicitis, many of those patients will actually remember having similar, albeit milder, attacks months or years in the past.
Yes, the history is crucial.
When pathologists look at these removed appendices under a microscope, they appear thickened with fibrosis, which is heavy scar tissue left over from those previous self-resolved bouts of inflammation.
It proves that the body often gives warning signs before the final emergency hits.
Here's where it gets really interesting, though. We've talked about what happens when the appendix gets blocked by standard inflammation. But what if the blockage isn't standard?
Oh, this is the curveball.
What if we pivot to neoplasms? Tumors of the appendix. These are incredibly rare, found in less than 1% of all appendix specimens. But when they are found, they turn a routine surgery into a massive oncological puzzle.
They absolutely do. When we talk about neoplasms of the appendix, we're classifying them into three main buckets:
Which are?
neuroendocrine tumors, epithelial tumors, and the extremely rare mesenchymal tumors, which include things like lymphoma or Kaposi sarcoma. But let's focus on the most common ones that surgeons actually encounter.
Right, let's look at neuroendocrine tumors, or NETs. These make up 30% of all appendix neoplasms, and they have a very specific hiding spot. 70% of these NETs are located right at the very tip of the appendix.
And because they're hiding at the tip and usually quite small, they rarely cause symptoms on their own.
Because they're not blocking the entrance.
Right, they don't typically block the base of the appendix to cause traditional appendicitis. They are almost always found entirely by accident during a routine appendicectomy.
How does that happen?
A patient comes in with standard appendicitis caused by something else. The surgeon takes the organ out, sends it to the pathology lab as standard protocol, and surprise, there is a neuroendocrine tumor at the tip.
And the pathology lab confirms it by looking for very specific chemical markers in the tissue. Two major ones are synaptophysin and chromogranin A.
Exactly.
Think of these like unique chemical fingerprints that only neuroendocrine tumor cells leave behind. Once the lab confirms it's a NET, the treatment protocol is dictated almost entirely by the size of the tumor.
Size is everything here. If the tumor is tiny, meaning under 1 centimeter, just taking the appendix out is usually enough. The appendicectomy itself is the cure.
But if it's larger?
If the tumor is larger than 2 centimeters, or if the lab determines it's a high grade, meaning a grade 2 or grade 3 tumor, which is much more aggressive, then taking out the appendix isn't enough.
The surgeon has to go back in.
Yes, they must perform a right hemicolectomy.
An oncological resection. That means taking out the entire right side of the colon. Why such a massive surgery for a 2-centimeter tumor?
It's all about the lymph nodes. The blood supply and the lymphatic drainage for the appendix are shared with the right side of the colon.
So they're connected.
If a tumor is over 2 centimeters, the risk that microscopic cancer cells have traveled into those local lymph nodes is too high to ignore. You have to remove that entire section of the colon to harvest those lymph nodes and ensure you've removed all the cancer.
That makes total sense.
Yeah.
Now, if the tumor is in that middle ground between 1 and 2 centimeters, it requires an individualized assessment.
True.
The patient will usually undergo a CT or MRI scan to check for any signs of spread before deciding if that larger surgery is necessary.
And even if those small, low-grade tumors are completely cured just by removing the appendix, the patient's journey isn't over.
No, they still need surveillance.
The protocol requires 5 years of close monitoring with CT scans and regular blood tests checking for tumor markers like CEA and CA19-9.
It's a completely unexpected, stress-inducing 5-year journey that started with what they thought was just a standard stomachache.
And as stressful as an unexpected neuroendocrine tumor is, the next category of tumors we need to discuss introduces a level of surgical complexity that honestly sounds like science fiction.
It really does.
We need to talk about epithelial tumors.
Yes, specifically something called LAMIN, which stands for low-grade appendiceal mucinous neoplasm. It's the most common of the epithelial types.
What makes LAMs so unique and so dangerous is how it grows. It has a pushing style of invasion rather than an infiltrating style.
What does that mean practically?
Instead of putting down deep, aggressive roots into the surrounding tissue like a tree, a mucinous neoplasm pushes outward as it produces massive, relentless amounts of thick mucus.
So it's filling it up.
The appendix essentially blows up like a water balloon filled with gelatin.
And that leads us to the terrifying consequence. If that balloon pops, if that mucinous tumor perforates, it spills all those microscopic, mucus-secreting cells all over the inside of the abdominal cavity.
Which is a nightmare.
This leads to the condition we teased at the very beginning of the deep dive, pseudomyxoma peritoni.
PMP. Colloquially and rather graphically called jelly belly.
The clinical presentation here sounds straight out of a horror movie. Because those spilled cells just keep producing mucus inside the abdomen, it leads to progressive abdominal distension.
The abdomen just keeps swelling as gallons of this jelly-like substance accumulate.
Gallons.
Yes. It coats the organs and forms what doctors call an omental cake, which is a solid, hardened shell of tumor and mucus that drapes over the intestines.
That sounds agonizing.
It causes profound anorexia and massive bowel dysfunction because the intestines are literally trapped in a thick layer of jelly.
It's a devastating condition, and the fix for it is arguably one of the most extreme, physically demanding surgical procedures in modern medicine.
It truly is.
You can't just scoop the jelly out. Those microscopic cells will just make more. The treatment requires two grueling steps. The first is CRS, or cytoreductive surgery.
This involves the surgeon meticulously going through the entire abdominal cavity and literally stripping away the peritoneum, the lining of the abdomen,
Stripping it all out.
and taking out every single visible tumor deposit. It's incredibly tedious, painstaking work that can take well over 10 hours in the operating room.
Over 10 hours. And that is just step one.
Right. Because once they've removed everything they can see with the naked eye, they have to deal with the microscopic cells they can't see.
Right.
That's step 2, HIPEC, which stands for hyperthermic intraperitoneal chemotherapy. The surgical team literally bathes the inside of the patient's abdominal cavity with heated, high-dose chemotherapy, usually a drug called mitomycin C.
Why does it have to be heated?
Thermodynamics. Heat expands the tissues, increases local blood flow, and essentially makes the cancer cells more permeable,
Allowing the chemo in.
allowing the chemotherapy to penetrate deeper and more effectively kill off those remaining rogue cells.
It's an absolute marathon of a treatment, which brings up a really crucial scenario. Let's go back to our bomb disposal metaphor.
I love this one.
What happens if a regular general surgeon is on call at 2 a.m., opens up a patient expecting a normal inflamed appendix, and unexpectedly finds a belly full of jelly?
It happens.
They aren't prepped for a 10-hour CRS and a hot chemo wash. What do?
This is where surgical discipline saves lives. The protocols lay out a very strict intraoperative surprise protocol.
A protocol for retreating.
It's basically a specific set of rules for how to safely retreat. Step 1 is systematic inspection and documentation. The surgeon needs to look around without disturbing things and meticulously document the extent of the disease.
For the next team.
That documentation is a roadmap for the specialist who will eventually take over.
Step 2 involves taking a sample. They do a careful biopsy of the tissue lining the abdomen, and they remove the appendix to get a definitive diagnosis.
But they have to do this without spilling any more mucus than has already leaked out.
And that leads to the crucial rule of this entire protocol. The surgeon must absolutely not over-dissect or disrupt anatomical planes.
It's human nature for a surgeon to want to clean things up and fix the problem in front of them.
To be a hero.
Exactly. But in this specific case, trying to scoop out the mucus or hack away at the tissue when you aren't in a specialized center is incredibly dangerous.
Tearing apart those tissue planes is like randomly cutting wires on a bomb.
It makes the future 10-hour specialist surgery much, much harder and significantly lowers the patient's chances of survival.
So the final step of the protocol is simply the abort strategy. Once the biopsy and the appendix are out, you abort the procedure.
You stop the surgery immediately.
Close the patient up and refer them to a specialized center experienced in peritoneal malignancy. You have to know when you're out of your depth.
It requires a massive amount of surgical humility. You scrubbed in to fix a problem, but the absolute best thing you can do for the patient's survival is to walk away and hand them over to a dedicated team.
It's truly incredible. When you synthesize all of this, you have to marvel at how a supposedly useless organ like the appendix can demand such profound surgical respect.
It commands the room when things go wrong.
We started this journey looking at standard inflammation, but today we saw the extremes. From navigating the immense, delicate stakes of a pregnant patient's abdomen, relying on MRI to avoid the devastating 20% risk of fetal loss.
To the rigorous post-op checklists.
Right, the top-to-bottom checklist, hunting down rogue bacteria, traveling the superhighway to the liver. And finally, to the surgeon who has to literally stop a surgery, step back from the table, and abort the operation entirely because of the sudden, shocking presence of jelly belly.
It proves that in medicine, there's no such thing as a truly routine case. The human body is always capable of throwing a curveball that requires immense skill, critical thinking, and sometimes the humility to just stop.
Exactly. Well, we've reached the end of our source material for today. As a quick reminder for those watching the videos, this is the second and last deep dive of our appendicitis series. Please make sure to subscribe, enable notifications, and let down the topic you want for our next deep dive in the comments below. You dictate where we go next.
And before you go, I want to leave you with a final lingering thought.
Let's hear it.
We've just learned that a seemingly routine, everyday appendicectomy can unexpectedly reveal complex neuroendocrine fingerprints or require a surgeon to immediately abort the operation to save a patient's future from an aggressive mucinous tumor.
It's wild.
It really makes you wonder, what other routine, everyday medical procedures are hiding similar, life-altering trapdoors just waiting for a surgeon to open them?
That is a fascinating question to chew on. Thank you so much for joining us on this deep dive. We'll see you on the next one.